Thank you so much, and it's lovely to be here. Slightly daunting to follow Andrew Dilnott. And just one thing that I think, as analysts, I've learned from Andrew, and I'd encourage you all to think about, is great data and great thinking goes a long way, but your ability to tell a story for people that is meaningful from that data is really important to having impact. And I think you just saw a masterclass of how to take data, theory, and turn that into insight by being able to tell stories. So one of the things that we're keen to do at the Real Centre in our work is to bring together data and evidence, and in particular to think about what that means for the longer term. And that reflects, I think, one of the things that I think an analyst can do, which is incredibly important, is to try to provide a bit of a counterweight in the system against the absolute imperative of the short term and the immediate. Those who run our healthcare system have two jobs, and balancing those two is incredibly difficult and unenviable. They have the task of ensuring that health and care systems are as high quality and as efficient as they can be today, but also to be a leader in our health and care system is an act of stewardship. It is also to ensure that they leave a health care system that is fit for purpose and able to meet the challenges of the future. And one of the things that I think, if you are a leader in the healthcare, is the urgent is very visible to you immediately, and everybody is asking for your attention on that. And if you're leading at the moment, it really, really is incredibly difficult. Good analysis, I think, can help to remind people about the future. And that matters not just because how we prepare for the future counts, but also because often, actually, in the way that we deal with the short-term pressures, we'll have choices which have different implications for the future. And they might not seem that different in terms of addressing today's problem, but if we think about them with a future lens, they look very, very different. And so the choice set and the optimal choice set might look very different if you're focusing not just on the here and now, but also on the future. But I think, therefore, it's really important as analysts that we focus on the future, but that we also help people to understand the future in ways that are meaningful for them. And so my colleagues in the Real Centre have been doing a body of work. We've been doing this now for about 5 years, this work, in partnership with the University of Liverpool, trying to bring together different data in order to understand what are those longer term trends. And we've looked at them out to 2040, long enough for some underlying trends to start to play out, but not so long that we're in the fantasy world of Star Trek. And we tried to think about that in terms of patterns of disease and then what that means for provision of care and, most critically, funding. And I'll talk you through our results, but as I do that, I might pull out a little bit, I think, what are some of the interesting things in terms of the way we're able to do the analysis. So the first thing that I want to talk through is, so what we do in this work is we look at patterns of major illness, and we use a measure called the Cambridge Morbidity Score, which allows us to combine different long-term conditions. And we look at 20 long-term conditions, which together account for around 2/3 of the burden of morbidity. And the Cambridge Morbidity Score, just to give you a sense of anchoring of that, what we say is anybody who's got a score of 1.5 or more, we classify as major illness. Now, to get a score of 1.5, there are only two conditions which on their own would get you at or above that, and that's cancer and dementia. Dementia has the highest impact. And that the weighting is based on the impact on mortality and the impact on health service use. So we've picked that score because we're thinking about the health system and what is important to the health system. Other measures of illness and outcomes are available and are important. There's no one perfect measure, but this seems relevant to us because we're thinking about the health system. The other thing that's important then is that it gives us a way of combining different conditions to think about their collective impact. So what we look at is anyone who's either got an individual condition that's 1.5 or above, so they've either got cancer or dementia, or a combination of conditions which together get you over that score of 1.5. And so most people here will be a combination of conditions rather than a single condition. And so what we look at is back in 2010, on average, at what age did people get some illness, any of our 20 conditions, and then at what age did they reach the threshold of major illness? And they reached the threshold of major illness in 2010 on average at 70.7 years of age, having lived for 23.5 years with some illness. Yeah? That means that on average, people live for 47.2 years without any illness at all. Scroll forward to 2019, yeah, and what you see is very little change in the age at which people meet that threshold of major illness. It's now 70.4. Actually, we're diagnosing some illness earlier. This is diagnosed illness, which is another illness. So we are diagnosing people with some illness earlier. So the number of years people are living with no diagnosed illness is down to, it's actually 45 years. But alongside this very static age at which people are developing major illness, we've got, albeit life expectancy increases have slowed, life expectancy increases through that decade have still continued. And so life expectancy through that decade had gone up by almost a year, from 80.6 years in 2010 to 81.7 years in 2019. The upshot is that people are living longer at the end of their life with major illness. And so through that decade, the government said, we are spending more money on the NHS. We have got more staff than we've ever had before. All of these things are true. And yet, if you went round the NHS, everyone would say, we do not have enough money. We do not have enough staff. Our quality is deteriorating, access is deteriorating, and it's a problem, yeah? Well, and so you go, well, both these two things can be true, yeah? And they are true, and they can be true because of this effect. So we were, healthcare is, for those of you who are Lewis Carroll fans, the Red Queen phenomenon. You have to run to stand still. Health need is changing. It changes quietly, yeah? And many of us who work in the system will have a sense of bits of this, yeah? But actually the reality of that change is not necessarily uppermost in my mind. We talk about an ageing population. Andrew mentioned ageing population. But what does it really mean to have an ageing population with earlier diagnosis of conditions and rising multimorbidity? It is this. And then when we project forward, looking both at population change, the ONS estimates of population change, and then also looking with Liverpool and their epidemiological modelling at trends in smoking, obesity, the classic risk factors, diet, exercise, etc., existing patterns in illness that we know linked to deprivation, linked to geography. When we project that forward out to 2040, what we find again is the age at which we get diagnosed with any illness falls a little bit more, but not by as much. The period, therefore, that we're living with some diagnosed illness increases slightly to 26.4. But the age at which we are diagnosed with major illness is stubbornly persistent at just over 70. But again, and we have to hope that this is true, that life expectancy continues to increase. So the number of years that we'll be living at the end of our life with major illness on average across society is expected to increase even further. In the jargon of these things, we're observing here an expansion of morbidity, a prolongation of the period before death when we're living with major illness. The health service's job, therefore, I think, is to ensure that those years are meaningful, high quality of life years, and then also to ensure that people have a good death at the end of it. To diagnose early, when diagnosing early can make a difference to that trajectory, and to support people to live as healthily as they can. But it's extremely challenging to think about how we can substantially reduce that effect. So thinking about how we help people to live well with major illness is really important. The other thing then is to think about, and this is power this data, what are the illnesses that people will be experiencing? And this is where one of the innovations of this work is that we were able to use the very granular level GP data. And I'm really pleased about that, because typically a lot of this sort of work has used hospital data. And so what you get in hospital data then is a preponderance of the conditions that lead you to be in hospital. And there are a number of conditions which are really important for morbidity, which don't tend to be so hospital focused. So what comes out of this work when we use GP data is how important chronic pain, diabetes, and anxiety and depression are, both in terms of the current pattern of morbidity and the increasing pattern of morbidity. Now, we obviously do spend a lot of time thinking about diabetes in the health system. We spend an increasing amount of time now thinking about mental illness, and we have the mental illness standards. And one of the transformations of my working career is going from a sense in which you go to meetings and people would say, well, obviously, mental health is really important, but the public don't think so, and we can't do very much about it, to the public thinking mental health is incredibly important. The service recognises it's important, and us trying to do something about it. But chronic pain already affects about 5 million people, and in our projections would go up to 7 million people, is a very common comorbidity. And I'm non-exec in Northwest London. I've non-exec for about 15 years, and I've never met a bit of the NHS which talks a lot about chronic pain and the challenges of meeting that and addressing that. And if you think about our economic performance, linking back to what Andrew said, and the things that keep people out of the labour market, mental health, anxiety, depression, and chronic pain are two of the very important factors. So even if you didn't worry about it so much in terms of health outcomes, there's also, I think, some important things to think about in terms of the employment and work and our economy. Yeah. So the ability to paint that big picture and then get down to the granular detail is one of the things I really like about this, because when you get down to the granular detail, that's when you start to think, okay, well, what do strategies look like to start to deal with this, to start to improve things? So that's the average person that I've talked through there. What does this mean then in terms of numbers? So when you then apply those that pattern of morbidity and life expectancy to changes in our population, what you see, exactly to that point about how difficult the 2010s were, was that we went from 5.3 million people, 3 million of them 70 or over, 2.5 million of them broadly of working age with major illness, up to 6.6 million. And very importantly, 600,000 more people living with major illness. And suddenly, in economic policy, this has become one of the most important issues of our day, because with the need to increase growth and actually unemployment still being relatively low, but rising economic inactivity due to ill health, that's really important. As you can see there though, our projections would imply that rising to 8.1 million by 2030, which is not very far away, another 600,000 people of working age living with major illness, affecting almost certainly their ability to work and their productivity, and that rises again to 9.3 million people. And this is a real challenge, because that's a 40% almost increase in the number of people living with major illness at a time when the working age population is increasing by 11%. Yeah? So that raises real issues in terms of workforce, in terms of you're thinking about the potential for technology to start to help with delivery of care. We haven't done this analysis regionally, but if you put all of this work alongside CMO's report this year, there's a geographical complexity to this, because the old people living with major illness are moving to some parts of the country, and the not very many new younger working age people don't live in those parts of the country and moving to different bits of the country. And a lot of our health service high-end facilities are in the parts of the country where the people living with major illness are not. Yeah. So you can see then a whole series of public policy questions, health service policy questions that follow from the allocation and provision of resources, model of care, workforce strategy, role of new technology. Yeah. That you need to start to think about, because none of that changes quickly. And then what does it mean for funding then? So what we do then is we combine, we look at the health service sort of at the moment just before COVID, because we haven't quite got our head around COVID. So we take the health service that we were delivering just before COVID, the demographic change that we would expect to be coming from the ONS, so rising population, changing age profile, geography. We then apply the population health projections that I've just talked about. But we then think about three other things. The cost of providing that care, and very importantly, how much wage growth we might expect and how much of that could be offset by productivity, what as economists we call Baumol effect. We look at the range of treatments and care that we want to provide, because that changes over time. And we look at how resources are used to deliver care. And looking at the range of treatments and the way we provide care is really, really important, because whilst demographics and morbidity explain a lot, there's a lot more going on than that, what many of you will know as non-demographic effects. And they are affecting different services in different ways, which is some of which may be intentional, some of which may be good, others of which I can't find anywhere where it said we intended to do this. And in most cases, what I can find in terms of intent is the diametric opposite of what happened, which might go back to Andrew's point about HMRC and the need for analysis to think about whether or not the policies that you're putting in place are really evidence-based and likely to generate the results that you want. So this is the change in activity, both pure activity, and then we cost weight the activity, because sometimes it's being different. The change over and above that you might have expected based on demographic effects and that changing pattern of morbidity. And what you see is that elective inpatients, once you cost weight, very interestingly, grew by less than you might have expected, but the cost weighted by more, suggesting that we were doing fewer but more complex things in hospital. A&E attendances have increased quite substantially, as have outpatients, over and above what is explained by demographic effects and morbidity. But GP consultations, all of this was the decade in which we were saying, again, for about I've worked for 34 years in healthcare as economist, and actually there hasn't been a time in that 34 years where we haven't talked about shifting care out of hospitals, upstream, into the community, into primary care, more focused on prevention, more focused on earlier diagnosis. Yeah? So policy actually has been remarkably consistent. I find it very difficult to see that policy in those figures. Yeah. So that raises to me something quite interesting, that if the key to this was another policy commitment statement and a belief in that, we would be home and dry. Yeah. But something clearly in the transmission between policy intent and delivery is happening. And so as analysts, I think, why is it that everyone in the NHS believes I mean, not everyone, but broadly, every NHS board, every strategy paper from the top all the way through says versions of that, and the reality seems very different. What you assume about what will happen to this mix is very important then for not just your aggregate funding, but where you target funding. So we look at a couple of scenarios, taking those two things into account. One is a minimal change scenario, where we look at the demography, that pattern of morbidity, fairly modest assumptions about that trend continuing, make pretty modest assumptions about NHS staff pay not getting worse relative to other workers, but not making up lost ground. The productivity after the shock of the pandemic gets broadly back to where it's been, that the investment in public health doesn't get worse, but doesn't grow very much. That capital spending is a bit higher, yeah? So this is, we call minimal change, yeah? And spending growth in real terms in this scenario over the next decade as a whole, which is at the very end there, and sorry, this is spending review jargon, but TDEL is a combination of the NHS England budget, wider health budget at Department of Health, and the capital budget. And that would have health spending increase year on year over a decade in real terms by 2.9% a year. Slightly higher in the next 5 years and slightly lower in the 5 years after that. But that's, where we are at the moment is in a health service that is really struggling with over 7.6 million people on the waiting list, us not meeting any of the core constitution standards since about 2015, not delivering that change in the model of care that I talked about, not shifting care upstream. So we then look at, well, what about if we tried to do quite a lot of the things that we've talked about before, that we tried to build a more resilient service to bring down waiting lists, to make us more able to deal with winter and future shocks, that we got back to the 18 weeks target within 10 years. We thought about a bit of catch up for staff wages. We really did try and invest in primary care, community and mental health services and make that shift and bring down emergency care use. That we recovered from the pandemic shock for productivity and did better long-term, harnessing the power of IT, AI and all of that. That we did actually try and invest something in the public health grant, get it back to broadly per person where it was in 2015, and that we really did invest in capital and modernise our health service. So if we tried to do those things, which are sort of what everyone talked about in their manifestos, and in policy documents, the implications of that for spending would be spending growth over and above inflation of about 3.8% a year over the 10 years, more front-ended in this case, more capital intensive. Yeah. And so how does that compare? And so over the long run, back to the sort of earliest data that we've got, which is available mainly for the UK, healthcare spending, to Andrew's point in consumption, healthcare spending in the UK increased by an average of 3.6% a year over and above inflation. And so we're saying is you need about 3.8% for that sustained improvement, minimal change about 2.9%. The IFS looked at the NHS's long-term workforce plan and backed out what that might imply for funding for the 15 years, and they get to a figure of 3.6%. So in essence, in our sustained improvement, we're in a very similar world to the world implied by the workforce projections. The OBR, in its fiscal risks, where it didn't think a lot about catch-up, but thought about those sort of bit closer to our minimal change, was talking about 3%. The OECD, looking not looking at the catch-up and challenges post-pandemic comes at around 2.1%. So the most important thing is all of these are positive over the long term. So 3.8%, if you're the Chancellor at the moment, seems completely unrealistic. But I think it's really interesting to look back then over the long term. There are 3 decades which had funding growth on a sustained period below that sort of historical average overall. The 1950s, the 1980s, when we were increasing our disposable income, not our public services, and then the 2010s. What you see, I think, is that after the 1950s and the 1980s, in which we tried to constrain health spending sort of below those cost and demand pressures, we then had 2 decades where we bounced back. And funding growth was actually much higher. So the interesting thing after the 2010s is that actually we have had decades before when we've held down health spending, but what we've done after that decade is then spent a lot more. Now we're arguing that a lot more looks quite similar to the historic average. But actually, what will happen if we're not somewhere close to that would be very much uncharted territory. The other thing, which I think it's really worth thinking about in this, is the extent to which this yo-yoing of periods of time where we try not to meet need and then we splurge to catch up leads to a more efficient and effective system. And whether or not actually, if we could get out of this cycle and just to slightly get over ourselves and recognise that healthcare is something that as we get richer as a society, as we age, it makes sense to provide collectively. We want to do that as efficiently and effectively as we can do. But actually the dynamics of that, the wonderful problem that we have is that the health service can do more. It's a huge prize. It's not a drag to say those last 12 years of our life, back to my first slide, the health service can help us to live meaningfully, yeah? To have a high quality life in that time period. That's not a cost burden to society. That's an enormous opportunity. If we could plan that better, accept that, might we end up with a higher performing, more efficient health system, which would be in all of our interests over the long term. And the other thing to think about when people look at this and because if I convert this into billions, it's huge, and everyone says, well, that's completely unaffordable and unrealistic. Probably if I'd put that chart up at every decade where we did spend more, if people had seen it, they'd have gone, well, that's unaffordable, completely unrealistic, and will destroy the economy and be politically unsellable, and then it happens. And the sky didn't fall in. And one other way to say just how off the scale unrealistic is this, and how avoidable is this, is to look at how the UK compares to other countries. And we do spend more than some countries, Greece, Portugal, Spain, Italy and Finland. Italy, about the same as Finland. But we also already spend a lot less than many other countries. Mainly, actually, that's not due to the fact that we spend a lower share of GDP. We do spend a lower share than Germany, Netherlands and France. But the big driver is that our GDP per head is lower. And so that has been a key issue. But I guess the other thing is that Germany, the Netherlands, Austria, France, who spend more, again, the sky has not fallen in for them. And the other thing which is quite interesting to think about, which is often, you know, where do you get sort of spurious solutions to important topics, is the problem that our system is tax funded. And people argue this in two ways. One is we can't afford it because it's tax funded. The other is because it's tax funded, you never get the money it needs. And if only we were a social insurance system, and there were a number of organisations, BMA and others in the early 1990s, who made a case for social insurance because they felt that tax funded system would always and forever be underfunded. But interestingly, a number of the countries that spend more than us, for example, Sweden's a good example, are tax funded. So all different ways of funding your health system, barring fully private, are in the top half of the distribution here. So, you know, it looks like this is a shared problem across high income countries. And to some extent, I think at the moment we're looking at it through the long lens. We are so focused on the how do we get this number down issue, rather than how do we extract meaningful value from what we spend. How do we get the most efficient and effective health service which supports our economic prosperity and supports people to live high quality, meaningful lives. Thank you. Are we? Do we? Am I coming down or staying up? Mm-hmm.
We've gathered a few questions for you. I'm just trying to...
Do you want us?
Have we got 5 minutes for questions? Brilliant. So these are questions that people have put through the Slido, and I've just picked a couple of them. Mm-hmm. The first one, I've got a feeling it might have been in the original thinking of Nye Bevan, but so one person asked, in your analysis, do we ever get to a point of equilibrium?
Well, we haven't gone beyond 2040 yet. And I guess if you look over long periods of time and what's driven healthcare, there are three factors that will lead you typically to spend more than GDP. So one factor is technological advance and innovation. So healthcare can do more each time, and you know, this decade, we're definitely going to have to figure out what to do about the obesity drugs. And if we're lucky, we're going to have to figure out what to do about the dementia drugs that might come on board. And obviously, both of those would be big, and they're just examples of that. And what technology obviously typically does is improves outcomes, makes us more efficient, but expands demand. And the demand effect has historically been bigger, than that. So that's one thing that tends to lead you to spend more. The second thing is what economists would call the income elasticity of demand, and healthcare is typically a normal good. So as we get richer, we want more of it. This, you know, we consume more, as Andrew said, but actually, healthcare is one of the things that we want to use our growing prosperity to spend on. And the third thing is this Baumol's effect, and Baumol's effect is basically the healthcare as a service sector. Its productivity, Baumol argues, you'd expect to be lower than whole economy productivity, because a lot of the quality comes from human-to-human interaction, And there's less scope to substitute machines for humans in healthcare than there is in advanced manufacturing. But to pay the workers in healthcare, the pay has to keep up with the pay of the people in advanced manufacturing. So pay in service sectors that are high human touch is determined by pay across the economy for us to be able to recruit and retain. That's determined by whole economy productivity. So our cost base, so we can't offset in healthcare growing wages fully by productivity. And so those three factors are three of the things that mean that healthcare is the Red Queen. You run to stand still.
Brilliant. And then one other, just a small question for you here. So you touched on in what you showed that in despite it being the prevailing policy objective for all that time that we should capture opportunities for upstream intervention and prevention, and that'll ultimately be the answer for squaring the circle. It just doesn't seem to be impacting when you look at a population level. So do you think that's an implementation failure? Is it just down to the fact that we haven't been prepared to make difficult spending decisions? Or do you think there's actually a bit of theory failure in the mix as well?
I think it's both. And we've been looking at this with Liverpool, and we started out sort of when we started this work assuming that we could do some scenarios where we were an infinitely healthier population. And that would be the get out of jail free card for the NHS, and with one leap we'd be free. But I guess what's become really apparent, which is often where something you kind of know, but then it isn't until you put everything together that you think about, is that most of the things we do with prevention do two things. They reduce the incidence, but they also reduce the mortality. And you need a heck of a big reduction in incidence to outweigh the mortality effect. And so yes, fewer people are smoking, unambiguously a good thing, but they're living longer, and while they're living longer, they pick up other conditions. And it's an example actually where some of the taking cost of illness studies and simply assuming therefore that you can save that cost of illness is almost certainly misleading.
Fantastic. Thank you, Anita.
Thank you.
Right. I think